recording. I'd like to introduce you to Dr. Matthew Eschelbach. Dr. Eschelbach is one of our assistant medical directors. He is the only one of the assistant medical directors that has stuck with us and does some extra work for us, thank goodness, because he does wonderful lectures. And he lectures on the EMS circuit up there. He's from Oregon, as you can see, medical director of EMS and trauma at St. Charles Health System in Redmond, Oregon. He has been around quite a while and has been teaching for us for quite a few years, and we're just honored to always keep him sharing his knowledge with you. As far as housekeeping is concerned, each of you, please keep your microphones muted, but if you have a question, you can unmute your microphone, get Dr. Eschelbach's attention, or type into the chat box and ask your question and go on. At some point, Dr. Eschelbach will probably be stopping and picking your brains, and I'm going to be watching as well. You do have to participate to get credit. So you've got to either answer a question, jump in there, do something to get credit. And that having been said, now that we're ready to start, I'm going to turn this over to you, Dr. Eschelbach, and I'm going to be locking the room. Before I do, if you have internet trouble and you have to drop out to come back, the room will be locked. So you may not be able to get back in. We do this because we had some issues with students showing up 15, 20, 30 minutes into the sessions and wanting full credit. So we will be locking the room. So Dr. Eschelbach, it is all yours.
All right. Well, good evening, everyone. We are going to do part 2 of childbirth and obstetrical emergencies. If you recall, last time we talked about normal delivery and then some problems with deliveries, primarily with presentation. And we're going to start now with the second part. Sorry. I don't know how that happened, but give me a second here. There we go. Got it. Sorry. There we go. All right, great. First on the docket is meconium. Now, the meconium is a thick, dark material. It's made up of the GI secretions of the child, and it's usually not secreted into the amniotic fluid. It's usually in the very first bowel movement of the child, but sometimes in fetal distress or a child that is overdue, you can have meconium staining. It's usually classified as light or heavy. Lightly stained is a yellowish green color, almost like bile. And the treatment is a standard bulb suctioning of the mouth and nose. And it complicates about 12% of birth. It's more common in women who are post-date and rarely seen before 34 weeks. But the problem with meconium, it is very, very toxic to the lungs. So if you see meconium, green meconium as a child is delivered, or if a lady's water breaks and you see the green meconium, you're gonna get yourself ready for giving ventilatory assistance to that child. It seems to inactivate surfactant, and surfactant we now can manufacture artificially, and surfactant is the material that pops open the lungs of a child. So in premature children who are born ahead of time, preemies, now we have the ability to give them artificially made surfactant, and surfactant will help with the lung maturity. But meconium can actually inactivate some of that surfactant. 35% of children who aspirate meconium wind up with some type of complication, whether it's a pneumothorax, up to 4% can actually die, and 66% or 2/3 can actually have some persistent pulmonary problems related to meconium. So if you see it, you've got to get it out of there as soon as possible. There is something called meconium aspiration syndrome. When meconium gets below the vocal cords, if that happens, that is a dire emergency, and we have to get suction to get that out. When you have a meconium delivery, you need to report it and let the attending physician know and the nurse know when this child is dropped off, if you delivered the child outside the hospital, or if you saw meconium when the waters broke, let the nurse or physician know. Before the shoulders are delivered, you want to get that meconium out of their nose and mouth as soon as possible. You want to assess the baby immediately, and if the child is vigorous and has good heart tone and strong respiratory effort, you don't need to suction the trachea. Most likely the child just got some meconium in their mouth. However, if the infant is depressed at the time of a meconium delivery, don't stimulate that child right away, because you need to do the best you can to get some tracheal suction. So you're going to have to pretend that you're almost intubating the child and use your suction material to get that out under direct visualization. You have to try and attach suction to an ET tube and withdraw deep suction below the vocal cords. Do not provide positive pressure until almost all that meconium is suctioned out. Most often, the baby can brady down, and you will need to give some positive pressure ventilation before all of it is suctioned out. If this happens in the NICU, if this happens in the operating room or something to that effect in the hospital, we usually have a neonatologist there, and they are very, very good at getting a little tiny meconium aspirator into the lungs and suctioning that out. And we have to be very, very careful with that. A meconium aspirator kind of looks like this. It's directed up to your suction. You can see in the right hand of, the left hand of this individual, they're going to keep their hand over the suction aspect. And in the right hand, they're going to try and get this tube down below the cords and suction out. Sometimes if there's nothing, if you take a peek at the cords and the cords look crystal clear, just get as much of the meconium out of the mouth and posterior pharynx as possible. All right, that'll lead us into very bit on newborn resuscitation. Keep in mind that this is not a NALS class or a neonatal advanced life support. This is only a brief overview of neonatal resuscitation. You want to make sure when you get a child who's delivering precipitously, precipitous means early, is this baby more than 4 weeks early? If it is, that's a little bit more urgent. If the water has broken, was it brown or greenish in color, which would indicate meconium, like we just talked about. Ask mom if she knows if there's only one child in there. Surprises can happen. You can deliver a child, and then next thing you know, you think you're done, and another one's on the way. Did mom use any drugs recently? Any type of medications, pain medication, anything like that? Because if so, the child might be respiratorily depressed. You're going to position the airway with the head slightly lower than the body, and then try and elevate the shoulders with a 1-inch pad if possible. Turn the infant's head to the side, suction the mouth first with a bulb syringe, and then do this 2 to 3 times, followed by suctioning of the nose. So mouth, then nose. If you go to nose first, it stimulates the child to take a deep breath in, and you don't want to do that, so that's why you go to the mouth first. Followed by suctioning of the nose with a bulb syringe and about a ½ inch into the nostril. Most of those new suction devices, the little bulb syringes that we have, you can't go too far on them. They are tapered, so you go in as far as you can and suction out the nose. If the nose is suctioned before the mouth, as I said, the newborn may be stimulated to take a deep breath in and inhale any fluid or secretions that are in the mouth. So mouth, then nose. And again, this is a bulb syringe. You can see that it is tapered, and you're going to depress it and then go into the mouth 2 or 3 times. And then after that, you're going to get removal of secretions from the nose. This is on almost any birth that you're going to do this because you want to try and get all that material. Remember, this child has been in a liquid environment for the last 9 months, and those lungs are just opening for the first time, and the surfactant that we talked about is the one that's going to pop open those lungs to help that child take good deep breaths. You want to gently stimulate the child, sometimes flicking a fingertip against the heel or lightly slap the soles of the newborn's feet. You can rub the lower back or tap the lower back. If needed, you can repeat this 10 to 15 seconds at a time. Don't hold the baby upside down. You don't have to slap the buttocks and squeeze or shake or immerse them in hot or cold water. These are all kind of old silly things that we see on television. Mostly just gently rubbing the lower back and then tapping the lower back is enough to get that child to stimulate and take a deep breath. I'm not going to go over this entirely, but this is a neonatal resuscitation protocol. It's probably something that you have in your protocols. All these things we already asked. Is there more than one? Is the child breathing? Is there good muscle tone? And then yes, go to routine care. No, you're going to warm and dry. You're going to position the airway as we talked about. Dry and stimulate. If they're breathing, good. If not, you're going to keep going down this left side here. If they're bradycardic and cyanotic, you're going to give them some oxygen by blow-by and some positive pressure ventilation. And we'll talk about this in a few minutes, but early on, you're going to begin chest compressions if their heart rate is low, and get that baby stimulated pretty quickly. Providing supplemental oxygen, you can do it after you stimulate the baby. If breathing without assistance, but the baby has little blue skin tones in the chest and abdomen, you can supply some supplemental oxygen, usually just by blow-by is all you need. With low flow at 6 liters or so, ½ an inch from the newborn's nose, blow-by will usually just pink that baby up pretty quick. Closely monitor the breathing and check that pulse. You want to make that pulse up around 100. Very, very quickly remember that 100 is tachycardia for an adult, but 100 is relatively slow for a newborn. Their heart rates usually are up around 150, 160. And this is just a picture of blow-by oxygen for the infant. When the newborn is receiving supplemental oxygen, if it remains blue after 30 to 60 seconds of supplemental oxygen, or he has a pulse or she has a pulse and it's less than 100, you're going to try and assist those ventilations at a rate of 40 to 60 per minute. Now, keep in mind that you're not going to give a full squeeze to assisted ventilation. These are tiny, tiny lungs, and you're only going to partially try and squeeze that back. If after general stimulation and the child is not breathing or has gasping respirations, again, assist the ventilations at 40 to 60 per minute. Use a bag valve mask with a snug fitting and attach oxygen to the reservoir, only enough to achieve chest rise. Now, that's only just a little, because these kids do not need, you don't want to give them a pneumothorax. You don't want to blow their lungs out. You just want to help give them enough supplemental oxygen and assess the breathing about 30 seconds later. Continue assisted ventilations, and if the heart rate, and check that heart rate, make sure you want to get it up to about 100. And there you go. Now, this is kind of a larger bag and a larger child. The bag itself for neonatal is probably about as big as an apple, and you're only going to do a little tiny bit. You're still, though, going to keep the same type of chin lift and try and get a good seal on the child as best you can. So keep that in mind as you're assisting ventilations. The pulse is probably the most reliable indicator of oxygenation and circulation in the newborn. We said that last time, that pediatric patients, usually if they're going to have an arrest, it starts as a respiratory and then leads to a circulatory arrest. So getting that pulse up as best you can to the 120, 180 is mostly because of good oxygenation. A pulse rate less than 100 indicates low blood oxygen. To assess the pulse, check a brachial pulse at the base of the umbilical cord. The baby's abdomen is one place. If the pulse is between 80 to 100, continue the assisted ventilations. And less than 60, you're going to begin compressions. Pretty quickly, this is going to be closer to 100. If the pulse is less than 100, you're going to begin compressions pretty quickly. Oxygen, it can be secondary. So you want to get that oxygenation up as quickly as possible, assess the pulse, and if you're getting to 100 to 120, you're doing well. If you're less than 100, you've got to consider ventilations and CPR. Usually you're going to have one or two people working with you at the time. So the neonatal guidelines here in advanced neonatal intensive care, assisted ventilation should be delivered at a rate of 40 to 60 to achieve a heart rate greater than 100. The ratio of compressions to ventilation is about 3 to 1, 90 compressions and 30 breaths to achieve 120 events per minute. This really should be 100. Continue chest compressions until the heart rate reaches 100 per minute. Continue assisted ventilations until the heart rate is also sustained at 100 per minute, and the child is breathing without assistance, 40 to 60 per minute. Keep in mind, this is when, if you're doing this, if you're at a home or on the way to the hospital, you should be already rolling by this time, but you're going to want medical control to know right away that you're having respiratory difficulty so they can get their neonatal team down to the ER as soon as possible. So here is the two-person technique, the infant and thumb technique here. This person is worried about the ventilations, and this person is doing chest compressions. They're only going to go down about an inch, or an inch and a half at most, because these children don't need a whole lot, but they're going to need stimulation. You're not going to put your hand on this child like you would an adult, because you'll wind up breaking ribs. Sometimes you have to consider advanced life support, which might mean intubation and possibly medications. Rarely these are needed, because most of the time just oxygen and a good strong pulse are all you need to get this child going. However, every once in a while, we might need drugs, and they can be life-saving. During transport, try and keep the vehicle warm. You should be hot. If you're hot and sweating, that's probably a good temperature for the child and the mom. You want to continue to monitor the baby's pulse and breathing and skin tones. And again, like I said, notify the hospital. Let them know you got a hot delivery coming, because they need to get their neonatal doc there. They need to get their OB nurses there to take care of mom. And the ER doc has probably got to drop what he's doing to help out if there's not OB or something like that at the hospital. Not every hospital has OB, but every hospital is going to have somebody who's trained in neonatal advanced life support. Alrighty, so now we're going to go on to some pregnancy complications.
Dr. Eschelbach, before you go any further, there's a
Yes.
few questions over here on the right. I think
Okay.
maybe be a good time. Hudson says, let's see, I'm going to go back here to the front one. Should EMS be moving to a model where we carry the artificial surfactant as part of our arsenal?
Boy, I would say no. That's a decision left up to a neonatologist. Even in the ER, I wouldn't give surfactant. I don't think it would be something that would not be used that often. It's expensive, and it would be something that doesn't get used, and it's extremely expensive surfactant because it's artificially made by recombinant DNA technology, and I think it would probably expire before you ever used it.
Second question, what is the best way to both identify and treat bronchospasm in a newborn?
Well, children aren't going to have typical bronchospasm like asthma. Again, you're going to listen to breath sounds, and they're going to be, kids' breath sounds are so fast and so rapid, it's hard to hear anything, and you're going to use a much smaller diaphragm. So you're not going to really hear wheezing per se. I can't tell you that you're going to use beta agonists like albuterol in a newborn, because the majority of the time they haven't had a chance to wind up with inflammatory lung disease. And so you're not really going to hear wheezing. If you hear coarse breath sounds, it's probably because there's water in the lungs, and their surfactant needs to open up the lungs, and the child needs to cough that out. And you need to assist the baby by tapping them on the back or something and suctioning to get their lungs clear.
What do you see the role of capnography in the scenario with meconium aspiration, and how can it be practically accomplished at the same time as suctioning?
Wow. You're thinking too hard there. End-tidal CO2, first off, I don't think you'd have the equipment small enough to give you an accurate end-tidal CO2. Children are going to have mixed gases to begin with. Their physiology is different than adult, so I wouldn't worry about that. I don't think end-tidal CO2, because they still have um, a patent ductus arteriosus. They still have two-way circulation early on, and their gases are so mixed up that I would leave it to a neonatologist. I wouldn't even attempt to do that.
And then apparently this happened to Hudson on Saturday. How do you recommend handling the birth of a child with a mother that is known to be COVID-19 positive?
Wow. Well, a lot of kids, COVID-19, the parents can be positive and the child can be negative. We have had that happen. So I would treat the mom as infectious, and you're not going to put a mask on a kid. You're going to be careful with airborne and aerosolized. They might have it. It's possible for a child to have it, but it's possible that the child does not have COVID-19 and the mom does. So I just universal precautions would be the best way to go.
And then Murph asks, and this is relative to a slide earlier, one of the ones with tables on it. What are we considering term gestation? And then he says is indicated in box 1.
All right. Again, we'll go back to the beginning. Where do we go here? Okay, this is do it. Our normal childbirth, again, I believe we're, give me a second. We're talking about 38 weeks is normal. So anything less than 38 weeks would be considered preterm.
Okay. I think that answers the question without.
Okay.
Yeah. And then
All
one last question before you move on. Well, I say that. How would you treat barotrauma injury to the lung in the newborn if you have an aggressive partner that's bagging the baby?
All right. Number one, don't do that.
Right.
Remember, don't, it's really, when you go to conventions, when you go to learning, they usually have a certain, I've done this myself, and you go to the neonatal table, and you can actually see and measure how quickly you're bagging or how slow you're bagging and how much pressure you're actually doing. Keep in mind that your adrenaline's gonna be going, and you can cause a pneumothorax. I would probably hesitate to say, treat the pneumothorax like you would anyone else, which is again a needle, because they're tiny, and unless you had a chest X-ray that confirmed a pneumothorax, I probably would not try to compensate with that child and do a needle thoracostomy. So don't be aggressive. Try and first take your own pulse, and then slow your breathing down, and then just make sure you're delivering quick, rapid breathing, and then talk to each other. I'm doing the ventilation, you're doing the CPR, and let's go 3-to-1 here. There you go.
All right, we got a couple more. We're just going to bog you down here. Lee says he's taken NRP and stable. Are there any other classes, certification courses that you feel like would benefit pre-hospital providers?
Well, there's PALS, Pediatric Advanced Life Support.
Which is required for our paramedic students.
Yeah, there's NALS, which is Neonatal Advanced Life Support. And those, again, when you take PALS or NALS, they're going to go over these, and they're going to be aimed at just the neonate. So it's worth taking one. They have them at the hospital all the time because nurses have to take them, delivery doctors have to take them, family physicians or pediatricians have to take them, and it's just a very common thing to do. So look at your hospital's CME department and sign yourself up for a course.
Okay, and Patrick Gibson, what are some common mistakes that you see from the pre-hospital setting that we should avoid when it comes to delivery and resuscitation?
Well, what I'm trying to do is go over the major problems here. So let's, we'll continue on pretty quick. But keep in mind that the major problem, most of these problems are kind of odd and don't happen very often. And very most often when a kid is and a child is born, everything's fine. But you have to be aware that there are other complications, and that's why I'm going over those today.
And do you use a PEEP valve with newborns?
No.
Okay. All right. I think that catches us up. I may have skipped one or two, but that way you can go ahead and move on.
If we have time at the end, we can always ask. Okay.
All right.
DIC, or disseminated intravascular coagulation, is a relatively rare, but it's usually associated with a profoundly ill mother. It can happen with preeclampsia, abruptio placenta, which we'll talk about in a few minutes, fetal demise, which sometimes happens, or sepsis of the mom or child. And it means that the mom can't clot because she's used up all of her platelets. And just keep in mind that if you can't stop maternal bleeding, the hospital needs to know so they can get things ready for a mass transfusion protocol. All right, we just handled a bunch of questions, so I'm going to move on. These are some more of obstetrical complications. Early pregnancy bleeding. These are terms that are kind of synonymous. Miscarriage is also known as a spontaneous abortion. Sometimes women have what's called an incompetent cervix, which is recurrent premature dilation of the cervix, and she's not able to hold the pregnancy. If that happens, it's usually up to the OB doctor to recognize that and put in a pessary or a stitch into the cervix. It's usually not recognized until one or two children have already had a miscarriage. Ectopic pregnancy, which we'll talk about in a little bit, and then a molar pregnancy, which we'll talk about in a little bit. Miscarriage is a pregnancy that ends before 20 weeks gestation. It's also known as a spontaneous abortion. 20 weeks is considered to be the point of viability. In all honesty, it's closer to 22 to 26 weeks. If you remember from last time, we talked about if the baby is at the belly button and you can feel the uterus at the belly button, that's usually about 20 to 25 weeks. And children above that have a chance of living. Children below that have a very difficult chance. Sometimes this is pushed down to 20 weeks. This is relatively rare. 25, 26 weeks is probably more where we can actually save the child. The signs and symptoms of a miscarriage are the presence of bleeding. Sometimes moms come into the ER and they're spotty, and you can have a normal pregnancy and a mom can be spotting, say at 14 to 16 weeks. There's different reasons for spotting, a few of which I'll show you in a minute. But all is not lost if there is spotting. But if you have bleeding and then mom feels uterine contractions or pain, sometimes just crampy pain, that's a little bit more concerning. If it occurs before 6 weeks, a mom may not even know that she's pregnant. And if she has an early pregnancy test and bleeds before 6 weeks, there's usually a problem with the pregnancy, and the pregnancy will just pass. And it could be just thought of as maybe a late period, and moms might not even know they were pregnant. Types of miscarriage. A threatened miscarriage is where mom is bleeding, and maybe we do an ultrasound and we see that the baby's okay, and the os, that's the cervical opening, is closed. So we call that a threatened miscarriage. Inevitable miscarriage is when the os is open and mom is actually passing some products of conception. A complete, where the os is now closed and all the products of conception have already been passed. And then a missed abortion or a missed miscarriage, the fetus has died but has not yet been expelled. Just this past weekend, I had a woman who had a normal ultrasound at 8 weeks, and then at 10 weeks, she no longer had a heartbeat, and she was bleeding, and that just would be a miscarriage. This is normal fertilization. We, again, from the ovary, usually fertilization occurs in the first third of the tube of the mom's ovarian tube, and the egg moves down and begins to divide into this thing called a morula. A morula is a division that's happened. Now you have an egg and a sperm have been mixed together, and now you've got the beginning of a child, and the morula moves down. It moves into the upper third to the middle of the uterus and implants normally. And that's usually where a normal fertilization will plant. An ectopic pregnancy is a fertilized ovum or a fertilized egg implanted anywhere outside the uterus. And as you can see, it can be in many, many places. Most occur in fallopian tubes, and very often we call them tubal pregnancies. That's what most people will call them, but it can occur anywhere. It can occur on the ovary itself, at the opening of the tube, in the tube itself, out here in the abdomen is rare, but it can happen. Further down in the tube, or way up here in the placenta, or sometimes down in the cervical os. This is a condition that is not consistent with life and will lead to mortality early in the pregnancy, and it can also hurt and kill the mother. Signs and symptoms of ectopic pregnancy are, first off, a missed period. So you have to suspect that a patient could be pregnant. And again, we try and say anywhere between the ages of 11 and 60 are possible. 11 is very early and 60 is very late, but some women do not go through menopause until their mid-50s, and some children can be sexually active or abused, and they can get pregnant early on. Usually they have abdominal tenderness, and there could be dark blood vaginally. It could be painful on one side or another. I mean, it could look like an appendicitis. And one of the first things we'll do in the emergency room, if we have a female patient who's of childbearing age and she's got abdominal pain, we're going to get a pregnancy test because it could be an ectopic. And you can sometimes just have pain referred to the shoulder because the nerves that innervate this area also innervate the shoulder. If the tube is not ruptured, some doctors can use methotrexate to dissolve the fetal tissue and maintain the patency of the tube so mom can become pregnant again. Sometimes they have to remove the tube surgically and remove the fetus and the tissue from the tube. And if there's a rupture, it usually means you have to have surgical removal of the tube. All right. Early bleeding, as we said, could be an ectopic pregnancy or a miscarriage. Late bleeding is a little bit more concerning. It could be placenta previa, abruptio placenta, and cord insertion into the placenta in various locations. Abruptio placenta is dangerous. It's premature separation of the placenta prior to the third stage of labor. The source of the bleeding is maternal from the uterine surface, and it's more common in women who are having hypertension or have had multiple children greater than 5, and for some reason, people of lower socioeconomic background. Maybe they're not getting ultrasounds that could pick up subtle changes, and maybe they have untreated hypertension, multiple reasons why it's higher. Abruptio placenta, as I said, is premature separation of the placenta. Part or all of the placenta may separate. So here is the normal placenta, which adheres to the uterine wall, and you have separation happening. Causes can include high blood pressure, perhaps cocaine usage, blunt trauma to the abdomen. That's why women who are pregnant, we monitor them for at least 6 to 8 hours after a simple motor vehicle accident to make sure that they're not going into labor. The grades of separation, you don't really have to know this, but there are different grades. Vaginal bleeding with tenderness in the uterus, but mom and baby are in no immediate distress is a low grade 1. Grade 2 is uterine tenderness, and tetany is a word that means firmness of the uterus. You may not have significant bleeding. Mom is okay, but the baby is very, very stressed. Grade 3 is severe uterine tetany. Mom is usually in shock, and usually the fetus has already died. Greater than 50% of the surface area has detached from the placenta. Suspect this. Cocaine use is notorious for this, and patients may come in with abruption. So try and do the best you can to get a good history from mom. Did you take any drugs? Did you have any trauma? What's going on? The symptoms of abruptio placenta, usually severe pain, fetal distress, dark bleeding with a very rigid abdomen, and then symptoms of shock, low blood pressure. This is a medical emergency. Management of abruptio placenta from the EMS standpoint is put mom in the left lateral recumbent position. If you remember, when you put mom in the left lateral recumbent position, you're taking the pressure off the aorta and giving the uterus as much chance to get oxygen as possible. 100% oxygen with a non-rebreather mask, wide open. 2 large bore IVs because mom can go into shock, and do the best you can to monitor both mom and the fetus. In the hospital, we'll put fetal monitor on so that we can hear. OB doctor might put a monitor in the head of the child if he can, to get a pulse of the child to see what's going on there. And placental abruption is usually managed by delivering the child right away. Sometimes a cesarean section or various ways of getting the child out through stimulating. If the child is already dead, that's another thing. But if the child is still alive, treatment is getting that child out. That's something that an OB would have to do. All right, second cause of bleeding is something called placenta previa. Most women will know if they have a previa. Most of the time, the placenta is up high, here or here, and in an ultrasound later in the pregnancy, they might know that they have a low-lying placenta, and a placenta that is close to the cervical os here, and the placenta can be implanted in a low region of the uterus, and if it begins to bleed, or if it's over the cervical opening or way down here, as the child begins to stir and as the child begins to get ready for delivery, this happens more often in women who've had multiple pregnancies, and usually the placenta is larger. And hopefully mom has had an ultrasound and she knows if she has a previa. The placenta actually implants lower than normal, and sometimes you get a different type of filamentous insertion where you don't have this Wharton's jelly protecting the cord. This vasa previa is relatively rare, and the cord can be easily lacerated. Risk factors for are previous placenta previa, perhaps again a previous C-section. Again, a normal placenta is way up here, and placenta previa is down here. Multiple births, smoking, and closely spaced pregnancies can sometimes lead to this, and maternal age over 35 years of age. The difference between placenta previa and abruptio placenta is usually it's painless vaginal bleeding late in pregnancy, and it's usually bright red. Remember, the other is abdominal pain with dark bleeding. It may not begin until labor begins. So if mom's starting to have labor and the placenta is starting and baby's starting to push, bleeding can happen here as the cervix is close to the placenta, and bleeding can happen early. You don't do a vaginal exam on these ladies. You keep the head of the bed at 30 degrees, 100% oxygen, 2 large bore IVs, and you're going to get them to the hospital so they can be monitored by OB. Placenta previa, one more time, versus abruption. A normal placenta is up here. Placental abruption is early separation, usually painful and dark blood. Placenta previa is usually painless with bright red blood. These are our local protocols, and you can see that we just have this as 2 little side notes. It occurs in the 3rd trimester. Lower abdominal pain, shock can develop, and placenta previa. The cervical opening can happen, and you need to deliver that child via C-section. All right, preeclampsia happens when there is a compromise in mom's metabolic activity. They get water and sodium retention. They get a decreased renal function, which is known as oliguria. They get an alteration in their vascular activity and increased CNS activity. The classic triad is weight gain, high blood pressure, and edema of the hands and face, and protein in their urine. So hypertension is not the hypertension that we talk about for most people with high blood pressure. It's a very small change in what the pre-pregnancy blood pressure is and the pregnancy blood pressure during pregnancy. That's why late in pregnancy, moms are going in every week. They're given a urine. They want to check their weight. They want to make sure they're not getting swelling and edema. Edema can happen to moms at the end of the day, but if they're waking up with edema in their hands and feet and there's protein in their urine, they're usually what we call preeclamptic. The pathogenesis, very busy slide, but there's sometimes diabetes, multiple births and high blood pressure, and you can wind up with placental ischemia, and preeclampsia can lead to eclampsia. We'll talk about that in a few minutes. Usually preeclampsia will develop after the 20th week of pregnancy. It can be mild with hyperreflexes, headaches, some visual disturbances, and nausea and vomiting. The definition of hypertension in pregnancy, this is what I was referring to before, consider an increase in the systolic or diastolic blood pressure of about 15 millimeters of mercury. So you could have somebody who's got a blood pressure of 125/75, and if their pre-pregnancy blood pressure was 80/60, that might be hypertension in pregnancy for that individual. Eclampsia is the progression of preeclampsia. Symptoms of severe preeclampsia with tonic-clonic seizures. So if you see a seizure in pregnancy, don't think epilepsy, you think of eclampsia. These people can go into coma or a hypertensive crisis. That baby needs to come out. Get them in a dark, quiet room, get them in the left lateral recumbent position. Oxygen again, 2 large bore IVs. Magnesium sulfate is the treatment for seizures in eclampsia, and consider sedatives, antihypertensives. The doctor will usually do this. Anticonvulsants can be given, like Ativan or something like that. But if you see a seizure in pregnancy, your first thought should not be for Ativan, it should be for magnesium. Magnesium blocks the uptake of acetylcholine, will relax the smooth muscle. It will also depress the nervous system. 2 to 4 milligrams over 25 minutes, and then a drip is usually started in the hospital. Side effects of magnesium can be drowsiness or flushing. They can break out in a sweat or diaphoresis. They can lose their reflexes, and their calcium can get very, very low. That's why the treatment for overdose of magnesium is calcium gluconate. Toxicity happens when there aren't any deep tendon reflexes. A long time ago, they used to have women who had premature labor on magnesium drips, and they were admitted to the hospital. and they were on magnesium drips to slow down their contractions and maybe give the baby a few more days to age. And when I was a medical student, you were up all night long doing deep tendon reflexes every hour on these patients. You can also get respiratory paralysis. The antidote for magnesium is calcium gluconate. Calcium carbonate is another way of giving it as well. For the high blood pressure, first choice is apresilene. It will cause vasodilation of the arterioles. It will decrease the mean arterial pressure and the systemic vascular resistance. Labetalol can also be used. Nitroprusside or nifedipine are also choices. Most of you don't carry any of these, but you might carry nitroglycerin, so you might have to talk to medical control. Our protocols: if seizure, follow the seizure protocol and consider magnesium right away. So very quickly, a case presentation. This is a real case that I had years ago. 28-year-old, gravid, 2, para 1 female, 32 weeks pregnant, complains of a headache. She takes Vicodin for pain and lies down for a nap. When she awakes from her nap, she calls 911 because she can't see, she's blind. She has no abdominal pain, no vaginal bleeding or discharge, and no difficulty breathing. Her vital signs: her heart rate was 90, respiratory 18, blood pressure 205 over 110. She shows pitting edema to the knees, and her face looks bloated. And as soon as EMS brings her in, she has a grand mal seizure. What do we do? Well, we had to get that baby out. That baby, OB thankfully came in because I was ready to cut that child out. And OB did some grand move where they pulled the baby out with stirrups and got the child out. And I took care of the child while they took care of mom. We gave her hydralazine, we gave her magnesium. We wound up intubating her because we had to actually do a surgical procedure to get that child out. And that mom used to come back every year and bring the child in to show us how well the child did. All right, so we're just about done. We have time for a few questions.
Okay, let me go back up here a little ways.
Like there's 34 questions.
Wow. Well, we'll try to ferret these down a little bit because I know it's 8 o'clock. So Hudson had a good question about hypertension in a pregnant mother. Should EMS reduce blood pressure under any circumstances, and if so, which ones?
I would contact online medical control. If mom is already on medication, you can talk to online medical control about giving her a dose of her medication. Again, it's kind of risky. I would get that mom in as soon as possible because mom is at risk, child is at risk. I wouldn't routinely treat mom's hypertension.
Okay. Joe Driver, our EMT student, says, why is cord compression not a topic discussed? Is there a way in the pre-hospital environment for checking for this?
Well, cord compression was in our last lecture, part 1. So if you want to go back online and look at part 1 of that, we talked about that's a surgical emergency, and you're going to do not deliver, don't put your hands on the cord, keep the cord wet, and go back. It should be online, correct, Jane?
Yeah, I think I've already got that one posted, yeah.
Yep.
It's in the MD Roundtable blog, right side of the coursework. There's a link for MD Roundtable. And we've had another discussion going, but I think we've answered it kind of amongst ourselves, different things about mothers and pregnancies and different things. We got onto a stethoscope because one of the questions that Chris Weber had asked had to do with, was there any other way to tell if the baby was alive, so to speak, without, and then I mentioned about learning how to listen to fetal heart tones. That you need to get good at that and finding them and knowing where to put the stethoscope and knowing how to listen for them. And then he said,
you're going to have a hard time with just a plain stethoscope.
Yes, and that was our discussion. And I told him, I said, I always bought a nice Littman, and that I didn't use the $5 stethoscopes the ambulance service provides. I always had my own stethoscope on the truck all the time.
And if you have a fetal monitor that has, it's a pretty simple thing. It's cheap to carry in the ambulance. You can hear fetal heart tones with it, and a little bit of ultrasound jelly, and you can hear heart tones. That's about, if you feel movement in the belly. Other than that, it takes hooking the mom up to a labor device.
I know because I flew in the helicopter for 2 years, so I have a little bit of hearing damage. And Littman has a wonderful stethoscope that allows you to crank up the volume so that you can hear. And I could hear a pin drop in the front of the truck with that thing, with my hearing problems. So, listening to fetal heart tones was no big with that thing. All right. Looks like somebody said, Hudson, what are your thoughts on IV access in the newborn if you cannot do a peripheral? Is there any big risk using an IO?
Well, in a newborn, again, hold on just a second. We already did that last time as well. But just to be very quick, I think I stopped sharing my screen, so give me a second here.
Yeah, this is a different group. Not all of them were in last time.
That's okay. Go back and read part 1. You got an IV already, and your IV is the umbilical cord. So if you cut the cord, and there you go. There's your IV right there. I wouldn't do an IO in a baby. You already got a big old vein right there in the middle. You could put a cannula in that. You don't even need the needle. Put it up to the hub, tie it off, and you can give fluid to the baby. I saw somebody asking about blood.
Yes.
This is the last here, right here. If you reach the umbilicus, if you can palpate the uterus at the umbilicus, this is chance of success up. Less than 20 weeks, the child is probably not going to make it. Giving blood, usually, unless there's a trauma, you're not going to need to give blood. Let me see what other questions I saw. Any other questions I missed here?
Well, Hudson said he was asking about the IO thing because they cannot use it in Georgia. It's not in the scope of practice. They freak out anytime somebody brings in an IO.
Oh, you can't use the umbilical. Is that what you're saying? Umbilical?
No, they can't use an intraosseous.
Oh, I see. All right.
That's just bizarre.
Yeah. You already got an IV right there.
Wait, no.
Belly button. You can't miss.
Oh, no. He's okay. You're confusing me, Hudson. Not UVC. The ED hates IOs, though. Okay. Oh, anyway. All right. Well, I think that's most of them, and everybody did participate. Laura, you did ask the question about the blood, and Dr. Eschelbach caught that one. So everybody did really well tonight. One more message popping up here. Some of them are sending to me. Oh, Laura said thank you. All right, everybody, we had a very good lesson tonight. Thank you, Dr. Eschelbach. We appreciate your time. Hopefully this captured well, and if so, then I should have it up in a few days onto the MD Roundtable.
All right, very good.
Thank you very much. Good night.